have no conflict of interest with regard to this presentation. If you have any questions regarding the presentation, I will be available to answer those in the live Q&A session at the end. The title of my poster is The Impact of COVID-19 on Local Nurse-Led Liver Services. And my name is Dianne Blackhouse, and I'm a clinical nurse specialist in hepatology at Hull University Teaching Hospitals. I have just over 2 years experience of working as a clinical nurse specialist, and I've worked in gastroenterology for the last 26 years with a particular interest in caring for patients with liver disease. To give you a little bit of background, the liver nurse service in Hull commenced in April 2018. It comprises of one full-time Band 7 nurse who delivers the day case paracentesis service, cirrhosis surveillance clinics and nurse-led liver discharge clinic, along with hepatology in reach to the acute medical unit and non-specialist wards. The liver team in Hull cares for 625 patients with cirrhosis. Prior to COVID-19, the liver nurse service performed on average 8.5 day case acidic drains per month. In addition, 5 discharge clinic reviews and 20 cirrhosis surveillance reviews were conducted weekly in the outpatient department. Up to 5 inpatients could be seen per day during the nurse-led hepatology in reach. The service is also a source of telephone advice and support for patients, carers and health professionals, and it receives a number of calls every day. The advent of COVID-19 has resulted in major changes for us all. Most liver services in Hull were suspended as the consultant team were deployed onto ED and the hospital wards in the Trust's effort to deal with the pandemic. Fortunately, the liver nurse role continued during this time, but with some changes. Firstly, routine cirrhosis surveillance clinics and scans were postponed. All surveillance patients were informed in writing of these changes, advising them to contact the liver team if they were experiencing liver-related problems such as jaundice, encephalopathy, or ascites, for example. The liver discharge clinic prior to COVID-19 was delivered on a weekly basis by a consultant hepatologist and the liver nurse. These clinics were independent of each other. During COVID, essential face-to-face reviews continued to be delivered by the liver nurse in the liver discharge clinic, with additional telephone slots created to increase capacity. The consultant clinic was changed to a general gastro discharge clinic in which liver patients were not reviewed. The day case paracentesis service continued during COVID with extra bed capacity available due to the reduction in other day unit activity. For example, routine biopsies and lumbar punctures had been cancelled, so therefore their beds became available for us to use. Also, the relaxation of clinical criteria for day cases assisted us in preventing admissions onto the wards. Unfortunately, due to increased workload in terms of discharge clinic and maintaining the day case paracentesis service, only a few inpatients were reviewed in terms of the nurse-led hepatology in reach service. But all of these were picked up via the liver discharge clinic. In the 4 months of lockdown between March and the end of June 2020, 23 patients received day case acidic drains. Some patients received up to 8 drains during this time as their ascites reaccumulates fortnightly. A total of 68 drains were performed as day cases during lockdown. This has resulted in the monthly average increasing up to 17 drains, which demonstrates a 100% increase in pre-COVID activity. This is demonstrated in figure 1 of the poster. Only one day case patient required admission to the ward, and that was because she rang on the day before my annual leave, and therefore we couldn't fit her in when she needed to be done. We all know that patients with chaotic lifestyles can find it difficult to commit to the routine nature of day case services, and during lockdown, 2 patients previously unable to commit to this now engage on a fortnightly basis. They also receive support from the alcohol care team at the same visit in the form of psychosocial interventions. To maintain the day case paracentesis service as COVID secure as possible and to reduce the risk of transmission between liver patients, all day case patients are COVID screened in advance. This commenced in May 2020. The patient is booked into a dedicated and documented bed space, so facilitating track and trace if necessary, and to date, no day case related COVID infections have been identified. The majority of patients who attend for day case paracentesis stated they found it beneficial from a psychological and emotional perspective, as this was often the only contact they had with others during that time. In terms of cirrhosis surveillance, during lockdown, 230 cirrhosis surveillance scans were due, but were unable to be performed as radiology has suspended most imaging. All 230 were reviewed to identify those at high risk of developing a hepatoma, for example, those with a raised alpha-fetoprotein, previous dysplastic nodules, or hepatitis B. Out of all those 230 that were reviewed, 16 priority scans were identified and ordered for those at risk of developing a hepatoma, of which 5 patients declined to attend due to COVID-19 phase, despite telephone contact by the liver nurse in an attempt to reassure them. This was demonstrated in Figure 2. The liver discharge clinic weekly reviews have doubled from 5 to 10 with the introduction of a telephone service, which many patients prefer, as once discharged they were not keen on coming back into the hospital environment during COVID-19. Telephone contact to the liver nurse service has increased substantially. Unfortunately, we don't have any pre-COVID exact figures, but during lockdown, 147 individuals, predominantly patients, but also carers and healthcare professionals, made contact between March and June 2020. The purpose for contact included treatment interventions such as diuretic tapering, arranging admission if required, general liver advice, emotional support, reassurance, and sometimes just for a chat, just to speak to somebody during that time. So in conclusion, the nurse-led liver service is an essential component of local liver services. New ways of working have enabled the continuation of outpatient and day case care for our most vulnerable liver patients, therefore preventing inpatient admissions during lockdown. Thank you for listening. And if you have any questions, please contact me for the Q&A session. Otherwise, you can email me on this email address and I'll get back to you. Thanks again.